At the outset, I would like to thank the organizers for inviting me to talk on one of the common health problem among the elderly, which in simple word we call painless visible hematuria. One might wonder why I am using the word visible. Here, the undergarments are stained first. So you may not see in the stream of the urine blood frank. So that's at the early stage. Later, it may be a different situation. We'll come to that. So the presentation is more on the what we call a genitourinary system. You can see in this picture, I have shown what systems are we talking of. This upper corner right picture shows what is the genitourinary system, starting from kidneys, which filter our blood and throw out these two stripes of ureter, and this is the bladder where urine is stored for a while before it is discharged. The second portion shows the different components of the structure. Now, keeping this in mind, we need to understand what is the issue we are talking of. Basically, when we talk of urinary system, we talk of kidneys. These are the top issues, the kidneys, which filter our blood and remove the waste in the form of urine. These are the different components which look like filters, which are called as renal pelvis or medullary areas and cortex. The blood comes through the blue vessels called as vein and get filtered. The urine passes through the pelvis ureter and to the bladder, get deposited here. You are not continuously dribbling as we know. So therefore, it has to hold. The capacity of this urinary bladder is only about half a liter. That means you can hold it. For a normal adult, one can hold from 3 to 5 hours. As age advances, the capacity to hold, even if it is up to 2.5, 3 hours, it is normal. The bladder, which is the issue of concern we're talking now, is a stretchy balloon made up of muscles. It expands to store urine and contracts when it is empty. Most people's bladder can hold, as I told you, about half a liter or 1 pint of urine. Urethra is the tube that carries urine out of the body, that is anything beyond this bladder. Most of our inside urinary system is covered by a special lining of human cells called transitional cells. These are the ones which misbehave and convert into urinary bladder cancer. Now, what does bladder means? Basically, as I told you, it starts in the transitional cell of the inner lining of the bladder. Because it holds urine for some time, the chances of infections are there. Whatever comes as a filtered one, if there are infected time, so that inner surface gets soaked for a while in all these contaminants. Usually, the human body cells follow certain pattern of what we call as growing, dividing, and dying, GDD, so that the inner lining keeps healthy always. Some fresh cells come, some old cells die. But sometimes, some of these cells may become errant and start growing either quickly or refuse to die when they should. In simple terms, they misbehave. And that is when it forms a lump, which we call in technical word a tumor. Bladder cancers are usually begin, as I told you, in the transitional cells of the bladder. Some tumors stay only in the inner lining, while some others can grow into muscle tissue behind this inner layer, which is the wall of the bladder, which contracts or relaxes. The deeper the tumor grows, the harder it is to treat. There are many risk factors implicated in development of bladder cancer. Cigarette smoking remains the most significant in the Western countries. But in the developing country, Middle East, Africa, and India, infections are common. In Middle East and Africa, infection from a parasite known as Schistosoma hematobium, the common term used is schistosomiasis, is a major etiological factor. In India, many other infections of the bladder are accountable for development of the cancer over the years. Now I walk you through two cases recently which are managed by us so that it gives you a picture before we discuss the integrities or nitty-gritties of the details. BKG, Mr. Balakrishna Gupta, is an 82 years old person. He is retired civil engineer, retired over 20 years ago. Known smoker, alcoholic, did not think of much when attendant said that you were undergarments.
I think someone is sounding.
Hello. Complaint of blood says on his undergarment while washing. He was keen thereafter, and in the second after a week or so, he got finded and informed, and they consulted the Air Force Hospital, where I have his son, who is a commandant in the Air Force. They looked at various blood biomarkers, which were almost normal. Urine cytology, that is the microscopic examination of urine, shows certain typical or atypical urothelial cells, which is an indication to suspect bladder cancer. But though these are indication, it is the indication of the entire urinary system starting from kidney to bladder. You cannot say a particular location. A high ratio of irregular and hyperchromatic cells suggests that there is a larger nucleus relative to the cytoplasm, which is an indication of higher motility and activity and potential malignancy. Later, a CT scan of kidney, the entire system, showed an ill-defined, mildly irregular focal mass near the trigone of the urinary bladder. Moderate left vesico-ureteric junction, resultant moderate hydroureter, marked hydronephrosis, thinning of the renal cortex with discrete areas of focal mark, cortical scarring on the left side. There were cysts in both kidneys. Endoscopy and biopsy was advised. Later on, since this continued, it was decided to do both scopy and resection, which is called as transurethral resection and biopsy of the bladder tumor, in short, TURBT. It is used to both diagnose and treat the bladder cancer. You can see the structure in the male in this ureter. This is a tube which is passed. There is a telescopic view, and it sees where the structure or the problem is there and also pinches it out. So after little anesthesia, a receptoscope, which is a telescope-mounted small electrified wire loop, this is the one, is inserted into the urethra until it reaches the bladder. Telescope allows the doctor to examine the inside of the bladder for signs of the tumor or the lesions. You can see the difference here compared to these things. If anything is present, the metal loop is used to cut and remove the dam. This is the metal loop. You can see this metal loop which is cuts that, and going through this natural opening of the system, the doctor need not have to cut anywhere in the abdomen or skin. Later on, the entire body PT scan is done to see if there are any migration of the tumor cells any over the body. In this case, there was nothing. In this case, the post-term and biopsy peril situation was usually, as usual, uncomplicated. The patient recovered in a speed of 1 week. Later on, a combined therapy after this is using chemicals and radiotherapy over a period of 4 weeks. The planning of this combined therapy takes sometimes, maybe 3 to 4 weeks. Therefore, this started in mid-July. He tolerated the therapy well. Sometimes people may not tolerate, they may have to get interruption. Here, the therapy was done 4 weeks continuously. The only problem he had faced was anemia, where intermittent blood transfusion was given about 4 to 6 pints to keep up the hemoglobin level. When we talk of a cycle, it consists of 5 days of chemotherapy and 2 days of radiotherapy. In the process, the person lost about 5 kgs of weight in only just 4 weeks. Naturally, he felt weak and lost hair due to the radiotherapy and chemotherapy. Constipation is common because the area which is to be radiotherapy done is delicate. Sometimes passing of urine and blood, blood in urine and stool is also done, but these are managed by laxatives, etc. After the 4 weeks treatment, now the person is able to move around, though the weakness continues. I will walk you through to another female case. The basic difference here, as you know, there is no lengthy urethra, so the cystoscopy becomes much easy. Here is a woman who is much younger, about 44 years old. He attended the outpatient, giving a history of gross hematuria. Here it was frank hematuria because she has come after 6 months, not in the initial stages. It also had increased her frequency of urination, and there was a sense of incomplete emptying every time she passed urine. Pelvic examination bimanual. Here in the women, we do vaginal and rectal. In between the bladder is felt. A mass was felt in the left flank near the bladder. Her serum biomarkers like creatinine and blood urea were very high, indicating long time inflammation, and complete urinary examination revealed microscopic hematuria with pyuria. Pyuria is pus in the urine. Urine analysis showed about 20 to 30 white blood cells in the high power field and more than 50 blood cells. Again, an ultrasound examination showed a 5 into 5 centimeter smooth lesion with peripheral hypergenicity at the base of the bladder near the left vesico-ureteral junction. There was a moderate hydroureate nephrosis. Right kidney was small with mild hydronephrosis. A non-contrast computerized tomography of the kidney, ureter, and bladder revealed a well-defined heterogeneous hypodense mass lesion measuring about 48 to 60, 45 by 60 millimeter in lumen of the urinary bladder arising from the base of the bladder. Exact site was left vulvo-urinary junction with moderate hydronephrosis. Right kidney was contracted and mild hydronephrosis was seen. The cystoscopy revealed a 60 to 5 centimeter endovesical tumor arising from the base of the bladder near UAG. Bilateral double ureteric stents were inserted due to obstructive uropathy. After 2 weeks, the serum creatinine reduced to 79 and blood urea to less than 8. Here again, a transurethral resection of the bladder tumor was performed and biopsies taken for histopathological examination. Again, the surgery was uncomplicated. Histopathology, that is the microscopic examination of these cells, showed intersecting fascicles of spindle cells with an elongated nucleus that was separated by connective tissue with the occasional necrosis with no mitotic activity and no cellular atopia. On immunohistochemistry, cells had positive staining for smooth muscle activities and Ki-67 suggesting a leiomyoma of the urinary bladder. So therefore, a pathological diagnosis of leiomyoma was made. Now, having seen these 2 cases, we summarize the public health significance and importance. The global burden of urinary bladder cancer, based on the recent international study, Globocon in 2022, there are expected nearly 20 million cases worldwide and about 9.7 million cancers that occurred in 22 and thereafter probably fatality is more increasing. Our estimation comes to around 21 million cases in 25 and about 10.5 million cancer deaths in 2025. Annually, there are about 6 lakh cases and there is an increase of 7% increase from year on year between 20 and 22. That means roughly 3% increase every year. As of today, we can roughly say 1 in 5 people or 20% develop cancer during their lifetime. This is overall picture. If you look at this disaggregated picture, it is 1 in 9 men and 1 in 12 men who die of the disease among those affected. This is the 9th most diagnosed cancer worldwide. According to the global estimate, there are about 5.25 100,000 bladder cancers in men, representing 5.4% of all new cancer cases, making it the 6th most common cancer among men. There are more than 53 million people living with up to 5 years after a cancer is diagnosed. Therefore, you can understand the burden of managing cancer. People do not die fast. Neither we wish they should die. The aging global population and socio-economic factors contribute to this increase. Coming back to Indian situation, this is also a common type of cancer in India. About 3% of all cancers in the country are urinary bladder cancers. The ratio of male-female is 4:1, 4 male cases, 1 female, based on the urban population-based canceries, because we do not know the real picture in rural India. Estimated bladder cancer incidence is about 22 to 23,000 cases annually, about half of them, 12,000, dying in India. How does it represent? Basic epidemiology of the urinary bladder. As I told you, the commonest symptoms in hematuria being very mild initially, the patient may not notice unless the undergarment particularly used or seen very closely. Sometimes there may be frequent mutilation and pain is felt much later. Compared to prostate cancer in the men, where it is known as a silent killer, many patients do not report having any symptoms prior to diagnosis. Associated morbidity and mortality have a major bearing on the quality of the life of elderly. As I told you, if diagnosed early and treated, people live for long. 5 years is the minimum average life even after detection. A significant proportion of the affected middle-aged individuals have a major bearing on what we call it the death-adjusted life years compared to the other malignancies. The burden of mortality and morbidity is different in high human developed index countries compared to middle and lower index, particularly among the men. There is a gap between men and women. As we told you, women suffer less. But this gap is closing, and it is expected that by 2040, both sexes will have similar level of incidence and prevalence. There are different types of cancers of blood. We'll come to that. Now, the more important science and this center is, here we distinguish the carcinomas into two categories. One is which are non-muscle invasive cancers. Second is muscle invasive cancer. Fortunately, the non-invasives are the maximum or 95%. The major concern of bladder cancer is highest lifetime treatment cost per patient. It represents a significant challenge in oncology given its wide range of disease risk, management option, and prognosis. The process of diagnosis, as we saw in both the cases, involves first a physical examination and digital screening. Physical examination, basically in men, it is examination between rectum and abdominal wall. And in women, it is between rectum and vagina to know the thickened wall of the bladder. Urine cytology is the clinching point as the initial non-invasive technique. Then a cystoscopy and biopsy is done, or what we call as TURB. Nowadays, AI is playing a bigger role of bladder cancer diagnostics, but developing countries, it's too early to think of this. AI modeling may help, but since the data is belonging to Western world, whether the similar data is indicative or are useful to the developing countries is yet to be understood. So this is a diagrammatic way of saying what is need to be done. Once you see a basic investigation camera, imaging of the abdomen and pelvis is the first one. One may look at IV, intravenous urography, CT or urogram or urine. All of them give you an indication. Other investigations include total blood count, diagnostic cystoscopy, or urine cytology, and CT chest, abdomen, and pelvis to rule out any secondaries. The non-metastatic ones are the non-muscle invasive and muscle invasive ones. Metastatic needs general treatment. As I told you, there are two types of urinary bladder cancer. One is a non-muscle invasive. Here, the cancer cells are limited to the inner lining or transitional cell of the bladder. They are not yet spread into the muscle, and most of the cases belong to this category in early diagnosis. This includes stages called TA, T1, and TIS, CIS. Muscle invasive bladder cancers. Here, the cancer cells are spread into the muscles of the bladder of wall, sometimes into surrounding tissues. This is more serious variety and makes up for a quarter of the cases. The types include T2, T3, and T4. At this stage, cancer is more likely to spread to other organs. The histopathological types, basically, when one examines under microscopy, we basically categorize them into urothelial carcinomas, which account for 90% or more of cases, and they remain among them. 75% patients present with pure urothelial carcinoma. Another 25 exhibit what are called as variant histopathology, which includes squamous, neuroendocrine, mucinous, nested, non-urothelial, which includes squamous cell carcinoma, neuroendocrine carcinoma, and adenocarcinoma. Non-squamous histopathology occurred more frequently in male. They are more often diagnosed at an advanced stages. In contrast, you typically diagnosed at early stages urothelial cancer. Among the non-urothelial subtypes, squamous cell carcinoma and NSUA are associated and have a worse progress. This is more details of squamous cell carcinoma, which is more dangerous and needs to be diagnosed. We won't like to go into the details of histopathology here. Treatment options, there are basically 4 or 5 strategies. There are in bladder treatment, medicines are placed directly into the bladder through a thin tube or catheter, and this includes what is known as BCG, which is a vaccine. It's an anti-tubercular vaccine, as most of you know. What it does is these weakened bacteria helps the immune system to attack cancer cell and get rid of it if it is in very early stage, or where the surgical intervention is not possible due to the personal or weakness of the individual. In terms of the surgery, it is the transurethral resection of the bladder tumor is the standard management across the world without cutting any part of the body. Sometimes, if the bladder is already involved or there is a metastatic, in advanced cases, the whole bladder may have to be removed, which is known as radical cystectomy. And here, though there is an alternative bladder system is man-made, the life becomes very miserable. The whole body treatment includes basically the chemotherapy and radiotherapy and immunotherapy. Chemotherapy is usually given either intravenously or oral tablet. I told you the combination of chemotherapy and immunotherapy, which is 5 days of chemotherapy and 2 days of radiotherapy. And there is something called as targeted therapy where the only cancer cells are attacked. Radiation is made using energy beams to kill the cancer cell or shrink the tumor size. Instead of using each one of them separately, combination of surgery, chemotherapy, and radiotherapy, as was done in our both cases, is more useful, and this is known as Trimodality therapy, where all three are used. After doing the TMT, radiotherapy is done. There are details are given what type of radiation is done, what chemical items are used. See, this is the area where one has to cover. Therefore, the planning takes longer time to protect other organs. Here, the entire radio-resistant garment has been prepared to fit the individual correctly. Otherwise, the other structures get spoiled. So therefore, this is again the same thing which is classified into what I have already talked. Now, patient where the bladder cannot be preserved is the choice where these are the different categories of cancers where bladder cannot be preserved. And non-surgical treatment or radiotherapy, usually we use about 6,000 to 7,000 RAD for the bladder. Chemotherapy, the drugs have already been indicated. Intravesical chemotherapy is placed directly into the bladder, as we already discussed. A combination of all these is what makes more significant inroad into the cancer. There is what is called as Y-chrome loss and immunotherapy. In the immunotherapy, Y chromosomal loss may influence immunotherapy, which occurs in about 40% of the male patient. This LOI has been associated with an aggressive disease, and therefore one has to be very careful in managing this case. Leiomyomas treatment is much simpler compared to the other one. Basically here, in more than half cases, treatment techniques used are transurethral sections. Only some cases where you may need chemo and radiotherapy. What is more important in the urinary bladder cancer is living post-treatment. As I told you, these people live on an average at least 5 years. So for them, follow-up care is very important. Go periodically to assess general health, treatment outcomes, identifying if any signs of recurrence. Monitoring recurrence, therefore, becomes a key task. Initially, it may be every 3 months, monthly, 3 months, and go on slowly. Maintaining a healthy lifestyle, adopting a balanced diet, regular exercise, avoiding tobacco use and alcohol use. Managing side effects, sometimes fatigue, changes in urinary function. Supportive care, it is just not medical care. The emotional support from family, friends, and others do make a lot of difference. Continue monitoring health, educating oneself and talk to people who have already undergone this exercise, and coping strategies, learning from others, balancing work and life if they are still working people, advanced care planning, regular communication with your medical team. To conclude, bladder cancer is one of the common types of cancer, particularly among men globally. About 3% of cancers in India and across the world are seen. Improving diagnostic capability across the world is increasing the number of cases. The treatment with maximum TURB and triple regimen therapy is standard procedure nowadays. Participation in bladder preservation approach requires a highly motivated patient. Emerging research continues to advance biomarker-guided treatment, non-invasive diagnostic, and personalized medicine. Mortality trend by gender highlight the urgent need for immediate intervention to expand anti-tobacco strategies, especially for men globally and in India and women in developed countries. Implementation of more strict occupational health and safety regulations. These are some references. Ultimately, I want to end my presentation saying empathy and efforts make living with urinary blood cancer comfortable. Families and medical fraternities must do their best. Thank you all. I once again thank the organizers for the opportunity given to me. Thank you very much.